Welcome to the Deep Dive. Today, we are tackling a really critical mission, giving you the essential framework for understanding the 9-month prenatal or antepartum period.
Right.
This deep dive is basically your shortcut to grasping the key signs, some surprising risks, and the diagnostic tools that really define modern pregnancy care. We're going to move pretty quickly, but stay focused.
Absolutely. It all starts with the most basic question, doesn't it? How do we actually know someone's pregnant for sure? Doctors have this three-pillar system for confirmation.
Yeah, I find this fascinating. It goes from subjective feelings right up to clinical proof.
Exactly. So pillar one is presumptive. These are the subjective things the person feels: nausea, feeling wiped out, breast tenderness, maybe a missed
The
period.
classic signs.
Yeah.
They only presume pregnancy,
No.
right? Lots of things can cause
It's
those.
precisely. They don't prove it. So then if the patient sees a provider, we get to pillar two, the probable signs. These are objective findings.
Things the doctor actually observes.
Correct. Like hormonal changes causing Hagar's sign, that's a softening of the lower part of the uterus.
Okay, and there's Goodell's sign too, softening of the cervix.
Yes, and Chadwick's sign, where the cervix gets a sort of bluish tint from increased blood flow. If a doctor sees these, it's highly probable.
Still not 100% though.
Nope. For that, you need pillar three, definitive diagnostic proof. We're talking ultrasound evidence, hearing a distinct fetal heartbeat, or positive HCG hormone levels.
And even with HCG, there's a difference, isn't there? Qualitative versus quantitative.
Right. Qualitative is just yes, no. Quantitative gives a number, and in early pregnancy, we really want to see that number doubling roughly every 48 hours. That's a key indicator.
Okay, so pregnancy confirmed. Now, setting the clock. Everyone thinks 9 months, but clinically it's 40 weeks. And the weird part is the person's only actually pregnant for about 38 weeks.
Yeah, it's a bit confusing. We calculate from the first day of the last menstrual period, the LMP. So conception happens about 2 weeks after that date we start counting from.
And that LMP is crucial for predicting the due date, the EDC, using Najole's rule.
That's the standard. First day at LMP, subtract 3 months, add 7 days. A simple formula from way back.
Okay, hold on. That feels like a major contrast right there. We have super sophisticated ultrasounds measuring tiny details, but the official due date often sticks with this simple LMP calculation. And doctors don't usually change it later based on scans.
Well, yeah, that's generally true. Early ultrasounds, say before 12 weeks, are very accurate for dating. But later on, babies grow at different rates, so those measurements can be less reliable for setting the date.
Ah, I see.
Nobil's rule gives a consistent starting point. If we kept adjusting the due date based on every later scan, it could get, well, chaotic for tracking milestones and interventions. So that initial estimate often anchors the whole timeline for consistency.
Makes sense for management. Okay, so that fixed date divides the 40 weeks into 3 trimesters. First one, weeks 1 to 12. That's when everything major forms.
Pretty much all the main body structures appear. It's also, often when morning sickness and fatigue are worst.
Then the second trimester, weeks 13 to 27,
Yeah.
often called the honeymoon period.
Often, yeah. Energy might return, nausea subsides for many.
And the third trimester, week 28 onwards, is all about growth and getting ready.
Exactly. Organs are refining, maturing, getting ready for life outside. It's finishing touches and weight gain.
All right, let's shift gears to specific groups who face unique challenges. Starting with age-teen pregnancy. The rates are thankfully decreasing, but the risks are still significant. Why is that?
It's largely because the mother herself is still developing. Her own organs, like her brain and liver, aren't fully mature.
So pregnancy puts extra strain on a body that's already working hard growing.
A huge strain. And that's linked to higher rates of preterm delivery and babies with low birth weight. Medically, it's tough.
And the sources really highlighted the social and developmental risks too, things like dependency.
Absolutely. They often rely on family or the state for essentials: housing, food, insurance. They're usually not equipped to manage that independently.
And developmentally,
Their brain is still developing executive functions. They're biologically geared more towards, high school concerns, not the immense stress and responsibility of a newborn. This mismatch.
between their developmental stage and the demands of parenthood.
Exactly. It leads to high stress, poor coping sometimes, and sadly, that environment can increase risks for the baby too, like intellectual disability or even issues of abuse or neglect stemming from that overwhelming stress and immaturity.
Okay, now flipping to the other end, advanced maternal age, AMA, that's 35 and older. Different set of challenges here.
Definitely different. The main issue is often pre-existing chronic conditions, things like high blood pressure, thyroid issues, maybe underlying heart conditions.
Which pregnancy makes worse?
It absolutely can exacerbate them. The body is under stress, so we see higher rates of complications like gestational diabetes, hypertension during pregnancy, low birth weight, and placenta previa.
And the big one everyone knows about with AMA is the genetic risk, right? Specifically Down syndrome.
Yes, the risk increases significantly with age. That's why tests like the quad screen and often diagnostic procedures like amniocentesis are routinely discussed and offered to women 35 and older.
Okay, moving from age to, well, fuel. Nutrition. The basic guideline is an extra 300 calories a day.
Per fetus. So yeah, 300 for a single baby, 600 extra if you're carrying twins, on top of your baseline needs.
And we know the general avoids deli meat due to listeria risk, high mercury fish like swordfish, limiting processed stuff, sugar, sodium. But the real skill is tailoring advice, right?
Oh, absolutely. Generic advice only goes so far. Take an underweight patient who maybe doesn't have much money.
Can't tell them to buy expensive organic salmon.
Exactly. You focus on practical, high-protein, budget options, peanut butter, beans, lentils, eggs, things that pack a nutritional punch without breaking the bank.
Or the opposite scenario, say, an obese 14-year-old who's gained too much weight early on.
The key there is not putting her on a restrictive diet. You absolutely don't want her starving herself or the baby.
So what's the approach?
It's about improving the quality of calories,
Yeah.
swapping empty calories for nutrient-dense ones, like maybe switch that daily milkshake for a fruit smoothie with yogurt or protein powder. Small, sustainable changes.
And then there's the extreme. Hyperemesis gravidarum. Severe vomiting.
Yeah, that's a whole different ballgame. The priority shifts completely to stopping dehydration and getting any calories in. Fluid and electrolyte replacement are critical.
This is where that surprising clinical advice comes in. Any calorie is a good calorie.
Pretty much. If a patient is so nauseous they can only keep down, say, a fast food burger.
The doctor might actually say, okay, eat the burger.
If that's literally the only thing staying down, yes. Because at that point, getting some energy source and preventing severe dehydration outweighs the concern about empty calories. It's a temporary, necessary measure.
Wow. Okay. What about anemia? That seems really common in pregnancy.
Incredibly common, defined as hemoglobin below 11 GDL. Vegetarians can be at higher risk because plant-based iron isn't absorbed as easily, and overall protein intake might be lower.
When is the need for iron highest?
Usually the second trimester, that's when the mother's blood volume expands significantly to support the pregnancy.
So, iron supplements are often prescribed, but they have that notorious side effect.
Constipation. Oh, yes. So the advice has to be paired. Take the iron, but drink tons of water and keep walking or moving. It helps keep the bowels moving. Simple, but essential advice.
All right, let's dive into gestational diabetes mellitus GDM.
Okay, so this is basically carbohydrate intolerance that pops up during pregnancy. Often the hormonal changes of pregnancy put stress on the metabolism and sort of unmasked an underlying issue.
But the good news is it usually goes away after delivery.
For most women, yes, it resolves quickly postpartum. However, and this is important, it's a major warning sign. Somewhere between 15 and 50% of women who have GDM will eventually develop type 1 or type 2 diabetes later in life.
So it's like a preview of a potential future issue.
Kind of, yeah. Now, there are risk factors being older, overweight, family history, but standard practice now is that everyone gets tested for GDM, even if you seem low risk.
And that testing, it starts with the 1-hour glucose test.
Usually around 24 to 28 weeks, yes. You drink a sugary drink, wait an hour, and they check your blood sugar. The body should process that sugar relatively quickly, getting the level below a certain threshold, often around 130, 140 milli-GDL, depending on the lab.
And you fail that screening.
Then you go on to the diagnostic test, the 3-hour glucose tolerance test, or GTT. This one's more involved. You fast overnight, get a baseline blood draw.
Then drink an even sweeter drink.
Yep, a higher glucose load. Then they draw your blood again at 1 hour, 2 hours, and 3 hours post-drink. If 2 or more of those values are above the threshold, that's a GDM diagnosis. Or sometimes, if the initial HbA1c level is 6.5% or higher, that's also diagnostic.
Okay, this is where it gets really interesting, the risks for the baby. You mentioned neonatal hypoglycemia. Explain that again.
Right. So if the mother has high blood sugar circulating because of GDM, that sugar crosses the placenta to the baby. The baby's pancreas is usually perfectly healthy.
So it sees all this extra sugar.
And it ramps up insulin production trying to manage it. It works overtime, flooding the baby's system with insulin to keep the baby's own blood sugar normal in utero.
Okay.
But then the baby is born, the umbilical cord is cut. Suddenly, that constant supply of high glucose from the mother disappears instantly.
But the baby's pancreas.
Is still pumping out insulin at that super high rate. It hasn't gotten the message the sugar fire hose is off, so all that excess insulin rapidly drives the baby's blood sugar dangerously low.
Ah,
Hypoglycemia.
that's the aha moment. The baby's perfectly adapted system in the womb causes an immediate crisis right after birth.
Exactly, which is why standard procedure for any baby born to a GDM mother is checking their blood sugar right away, often multiple times in the first few hours.
Fascinating and a bit scary. What other risks? Macrosomia.
Yes, macrosomia means a large baby, typically defined as over 4,000 grams, or about 8 pounds, 13 ounces. All that extra glucose can fuel excessive growth.
And a big baby means a difficult delivery.
It can, yeah. Increased risk of shoulder dystocia, where the baby's shoulder gets stuck during delivery, which is an obstetric emergency. Also higher rates of C-sections.
Now, you also mentioned IUGR versus SGA. Clarify that difference again. It's not just about being small.
Right. SGA, small for gestational age, just means the baby is smaller than average, maybe below the 10th percentile for weight. Could be genetic, perfectly healthy, just small.
IUGR.
Intrauterine growth restriction is different. It's a pattern of growth that's concerning. It suggests the baby isn't reaching its growth potential due to some underlying issue. It's often about asymmetric growth.
Meaning,
Like maybe the baby's head is growing okay, but the abdomen is lagging way behind, or length is significantly restricted. That disproportionate growth pattern flags IUGR, signaling something might be wrong, placental issues, infection, genetic problems. It's a red flag about well-being, not just size.
got it. So managing GDM is pretty intensive then.
Oh, yeah. Once diagnosed, it usually triggers an immediate consult with a nutritionist. They'll likely recommend a specific diet, often around 2,200 calories, following American Diabetes Association guidelines balancing carbs, proteins, fats carefully.
And more monitoring.
Definitely. Increased blood sugar monitoring for the mom, sometimes 4 times a day, and usually weekly non-stress tests, NSTs, for the baby starting around 28 or 32 weeks. Plus, more frequent ultrasounds to monitor the baby's growth and check for macrosomia.
Okay, that leads us perfectly into the diagnostic toolkit used during pregnancy. Ultrasound is king, right?
It's the #1 tool, absolutely. Early on, transvaginal ultrasounds can give clearer images, but the standard, especially for things like the big 20-week anatomy scan, is transabdominal.
And what are they looking for with ultrasound?
So much. Confirming the heartbeat, seeing if it's twins or more, assessing growth over time, estimating weight, though that can be notoriously inaccurate later on, checking amniotic fluid levels, the AFI, and crucially, screening for physical anomalies, looking closely at the brain, heart, kidneys, spine, limbs.
The sources mentioned a protocol for suspected fetal death.
Yes, it's a very difficult situation, but the protocol requires rigorous confirmation. Usually it needs confirmation by ultrasound, performed by the attending physician or house officer, followed by a second independent confirmatory ultrasound by a radiologist before any irreversible steps are taken. It ensures absolute certainty.
Okay, then there's the non-stress test, the NST,
Yeah.
done when the mom isn't in labor.
Correct. The non-stress part refers to no labor contractions. We're monitoring the baby's heart rate and watching for accelerations, usually linked to fetal movement. The mom often has a little button to press when she feels the baby move.
What's it checking for?
Basically, neurological well-being. A healthy, well-oxygenated baby with an intact nervous system should show heart rate accelerations when it moves.
So how do you pass? What makes it reactive?
The standard criteria for a reactive NST is seeing at least 2 accelerations within a 20-minute period, though sometimes it's assessed over 15 minutes.
And an acceleration is.
Defined as the heart rate increasing by at least 15 beats per minute above the baseline rate, and that increase needs to last for at least 15 seconds. The 15 by 15 rule.
2 of those in 15 or 20 minutes means reactive, pass. What if it's non-reactive?
If you don't see those 2 accelerations in the time frame, it's non-reactive. It could mean distress, but often the baby is just asleep. So a non-reactive NST usually leads to the next step.
The biophysical profile, or BPP.
Exactly. The BPP is done via ultrasound and gives a more comprehensive picture. It scores 5 things, each getting 0 or 2 points.
What are they looking at?
Fetal breathing movements, practice breathing,
Uh-huh.
gross body movements like limb movements, fetal tone, flexing, extending, amniotic fluid volume, and the NST result itself is often included as the 5th component.
So it's scored out of 8 based on the ultrasound parts, or 10 if you include the NST.
Right. A good score, like 8 or 10 out of 10, is reassuring even if the NST was initially non-reactive. It often just confirms the baby was snoozing. A low score, however, is concerning and might prompt further action, possibly delivery.
Okay, another important one, amniocentesis. This is more invasive.
Yes, it involves inserting a needle through the abdomen into the amniotic sac to withdraw a small amount of amniotic fluid. It's usually done around 15 to 18 weeks for genetic testing, often related to AMA or abnormal screening blood tests.
But it can be done later, too.
Yes, in the third trimester, it might be done to check for fetal lung maturity if early delivery is being considered, or sometimes to check for infection inside the uterus.
What are the risks? You mentioned the uterus is a muscle.
Exactly. Sticking a needle into it can irritate it and cause cramping. There's a small but real risk of infection, bleeding, leaking fluid, or even triggering preterm labor or miscarriage. It's guided by ultrasound to minimize risk to the baby and placenta, but risks exist.
Okay, lastly, RhoGAM. This is specific for Rh-negative mothers.
Correct. If a mother's blood type is Rh negative, like O negative, A negative, etc., and the baby's father is Rh positive, the baby could be Rh positive.
And that's a problem.
It can be. If Rh positive fetal blood cells mix with the mother's Rh negative blood, which often happens during delivery or miscarriage or even amniocentesis, her immune system might see the Rh positive cells as foreign and create antibodies against them.
Like an allergic reaction.
Sort of. It doesn't usually affect the first pregnancy much, but those antibodies stick around. In a future pregnancy with another Rh-positive baby, those maternal antibodies can cross the placenta and attack the baby's red blood cells, causing serious anemia, jaundice, even death. It's called hemolytic disease of the fetus and newborn.
So RhoGAM prevents that sensitization.
Exactly. It's an injection of anti-RHD antibodies. It's given around 28 weeks gestation and again within 72 hours after delivery if the baby is confirmed to be Rh positive. It essentially mops up any fetal Rh positive cells in the mother's system before her immune system can react and build its own long-lasting antibodies. It protects future pregnancies.
Crucial preventative step. And just quickly, medication safety categories.
Yeah, the FDA used to use letter categories, though they're moving away from it. But historically, A and B were generally considered safe. C meant risks couldn't be ruled out. So use only if benefit outweighs risk. Lots of antibiotics fall here because the risk of untreated infection is often worse.
V.
D meant there's positive evidence of human fetal risk, but benefits might be acceptable in life-threatening situations. And X meant absolutely contraindicated studies show fetal abnormalities. Risks clearly outweigh any possible benefit. Think chemotherapy drugs, Accutane.
Wow. The amount of detail and intervention needed is just staggering when you lay it all out.
It really is. From just feeling tired or nauseous, all the way to interpreting complex NST patterns or managing GDM with precise diets and monitoring. It's a journey.
It underscores that pregnancy care is fundamentally about constant, highly personalized risk assessment.
Couldn't agree more. Every step involves weighing risks and benefits for both mother and baby.
So reflecting on everything we've covered, what's a final thought for our listeners to chew on?
Well, what stands out to you from this deep dive?
For me, it's that stark contrast we hit on earlier. We established the entire 9-month timeline based on a simple, almost quaint formula from the 19th century LMP minus 3 months plus 7 days, an estimation.
Right.
Yet the moment a specific risk like gestational diabetes appears, the response flips to this incredibly high-tech, data-driven precision. Daily glucose logs, weekly fetal monitoring, interpreting tiny heart rate changes, meticulously calculated 2,000-calorie diets. That blend of broad estimation and intense microscopic focus living side by side that really captures the unique nature of managing pregnancy today. It's fascinating.